Trauma session B. We have around 4 contestants today. First, I'd like to invite Dhar sir for introducing the concept and welcoming everybody. Dhar sir, thanks, sir.
Yeah, good evening, everyone. Welcome once again to this trauma session of the Rising Star of Bombay Orthopaedic Society. I thank Ashok for allowing me to start this session as usual. As you all know, this is about the young orthopedic surgeons who BOS provides the platform to present their research skills, presentation skills, and their own uh, innovations while practicing orthopedics in last 4 5 years. So I'm grateful to Bombay Orthopaedic Society for allowing this session to be continued as it is getting popular every year. So this time we have, I think, 4 contestants today, and the judges, Dr. Satish, Dr. Ashish, Dr. Sachin Kale. I think Dr. Harshad also was there yesterday. I hope he has joined. All of them are established trauma surgeons, and they are there to judge. So I hand it over back to Ashok for giving you the guidelines and the rules. Thank you.
Thank you, sir. I'll invite Dr. Neeraj Bijlani for explaining the rules and welcoming the judges.
Yeah, hi everyone. So the rules are simple. There will be a 7-minute presentation by the speakers and it will be 3 minutes Q&A. So please stick to your time and see to it that your video is on and your presentation is tested. And I would like to again introduce today's judges. Today's judges is Dr. Ashish Phadnis, who's Director of Orthopedics, the Secretary of the Bombay Orthopaedic Society, and a very good trauma surgeon and a very good dear friend of mine. The second judge is Dr. Satish Mutha. He is a consultant trauma surgeon in Hinduja Hospital and various hospitals in Mumbai. And he is also, we are hoping that he will be the future president-elect of the Bombay Orthopaedic Society. With this, and we have also with us Dr. Sachin Kale, professor and head of unit in D.Y. Patil Hospital in Navi Mumbai, and he will be joining us shortly for the first session. So with this, I hand over back to Dr. Ashok to conduct.
Arshad has joined.
Thank you very much, Neeraj.
Arshad is also here.
Yeah, sorry, I was a little late.
Judge is Dr. Arshad, who's a associate professor and head of unit of Cooper Hospital, and he is also the Virox. He was also the Virox secretary in 2017 with me and a very good dear friend of mine. With this, I hand over to Dr. Ashok to start the proceeding.
Thank you very much, Neeraj. So I'd like to invite the first contestant, Dr. Avinash Upadhyay. Dr. Avinash, please share your screen and we can start your presentation. Okay, we can see your screen. You can start.
Good evening, everyone. Am I audible, sir?
Yeah, you're audible.
Yes.
Go ahead.
Yeah, you're clearly audible.
Good evening. I am Dr. Avinashdev Upadhyay. I thank Bombay Orthopaedic Society for giving me this opportunity. Today, I am going to talk about periprosthetic femur fractures around the well-fixed implant, ORIF versus revision stem, how to choose. Periprosthetic femur fractures after total hip arthroplasty are rising with aging population and expanding arthroplasty volumes. Type B Vancouver periprosthetic fractures form the majority of these. Differentiating B1 versus B2 is critical because it determines the treatment strategies. I found the paradox that ORIF around a well-fixed stem reported higher failure than revision around the loose stems. My objective is to review and compare ORIF versus revision stems for fractures around apparently well-fixed implant. and define decision points to select fixation versus revision. I would summarize last 10 years literature, highlight the practical algorithm for busy surgeons. For this review, I have studied the PubMed Medline, Google Scholar, last 10 years articles. I have included the systematic reviews, comparative series on B1, B2, Vancouver periprosthetic fractures. This is the Vancouver classification we all know. I would like to talk about B1 fractures. B1, the fractures around stem. The stem is stable. B2 fractures is fracture around the stem, but stem is loose with good bone stock. B3 is loose with poor bone stock. Andrew et al. Have mentioned that reliance on pre-op X-ray alone misses up to 20% loose stems, which means it is misclassified B2 as B1. He has also mentioned in his article about happy versus unhappy hip concept by Coventry, and which means happy hip is a stable, well-functioning implant before the fracture. No premorbid hip or pain dysfunction is there. Normal function before the injury. There is no clear radiographic signs of loosening. These kind of fracture we treat with like a true B1 with ORIF. And unhappy hip suggests pre-existing stem loosening, even if the X-ray looks okay, previous hip pain, minimal trauma, radiographic loosening, or osteolysis. For such scenarios, we treat like B2 with revision long stem. In the same article, he had mentioned about occult loose stem, which is the silent B2. Femoral stem that is actually loose, but appear well fixed on the preoperative radiograph. Therefore, it is misclassified as Vancouver B1 instead of B2. Intraoperative dynamic testing should be done for such scenarios. Missing looseness is a major cause for ORIF failure in presumed B1. According to British Hip Society, they have given a surgical standard for management of total hip arthroplasty periprosthetic fractures, in which they have mentioned older, frail patient with multiple medical issue may not tolerate a long revision surgery. For such scenarios, ORIF should be preferred. And the patient who need immediate full weight bearing, like patient who have bed sores and lung infection, and such patients should undergo revision long stem. They have also mentioned about the fracture pattern, particularly transverse short oblique with comminution. These are prone to varus collapse, plate pull-out failure, non-union. These are less forgiving for plates. For such cases, revision stem should be used, even if you think it's B1. ORIF around a well-fixed stem, where in which cases it is successful. Andrew et al. Have mentioned that stable stem, good bone, reducible pattern. These cases are fixed with lock plates and cable. And this has very high union rate in the range of 83 to 96%. Failure rates are low, but still present. Advantages include shorter operative time, less blood loss, less length of stay versus revision in selected B2 and B3 cases, especially in frail, elderly, medically high-risk patient. And revision stem, for which cases we can do, it includes loose stem, B2, B3, cemented stem with poor bone stock, unstable fracture pattern with combination. This stable long stem that bypasses more than 2 cortical diameters, and it can allow early weight bearing. The gray zone can some B2 fracture treated with ORIF? Like traditional teaching, we know that B2 is there, B2 fracture always revise, but some B2s behave like B1s. These are selective B2s, which is mentioned by David et al. Vancouver B2 with specific lateral cortical fragment or distal stem stability may do well with ORIF. So I have developed a practical algorithm to clear this scenario. Like suspect fracture around stem, take a full history, check about the pre-morbid pain or dysfunction, check for the labs, high quality X-rays, and then if there is sign of loosening osteolysis, is the trauma sufficient, cemented stem with the poor bone stock, plan revision long stem. If likely B1, check for intra-op dynamic stability. If any doubt, then revise. If stable, ORIF with lock plates and with or without cable, span more than 2 cortical diameter, and frail high risk with borderline B2, consider ORIF if intra-op stability is acceptable. Otherwise, you can go for revision step. So my take-home message is don't trust the X-ray alone. Intra-op stability testing is decisive. True B1, we know that ORIF we should do. True B2, B3, revision long stint. Borderline B2 in frail comorbid patient may be ORIF candidate if intra-op stability is acceptable. Aim for early safe mobilization with durable construct. These are my references. Thank you for your patience listening.
Thank you very much. I'll invite judges for their questions. Satisha, you can start. You're on.
I think you have nicely simplified the whole thing. So I must congratulate. What is the sensitivity of this intra-op stability test or the distraction test or the traction maneuver test? And what are the fallacies of that? Did you read that? Was there any mention?
Yeah. So they have just mentioned that this have added to decrease in misclassifying the fractures from B2 to B1, but they have not specified that how much sensitive is it and how much we are able to uh, mi- uh, uh, wrongly classify these fractures. So there is no specific sensitivity they have mentioned in those studies.
Does any study mention preoperative fluoroscopic testing versus intraoperative decision making?
No, sir. There is no study which mentions these tests.
So,
Avinash, in your plating, in your B1 fractures, where they have used plate fixation, have they quantified as to which type of plate has a higher success rate, whether a dual plate works better than a single plate, or that's still left open? And second question is whether they have mentioned anything about cortical screw hold, whether there has to be bicortical or any methods by which whether a locking plate is superior to a non-locking.
So for the first question, I would like to answer that they have there are not many studies which compares the single plate versus a dual plate outcome for periprosthetic fracture specifically. And for second questions, they have few studies have do mention that locking plate is much superior than the normal compression plate dynamic compression that I have found.
Avinash, a good presentation. So basically what I wanted to ask is that you've done you've done literature review, right? So two, three things. Are any particular stems
Yes,
more
sir.
common in causing these periprosthetic fractures that you have come across in the series? Secondly, as Dr. Harshad mentioned about the plates, the plates have evolved, our techniques have evolved. So have you found any change in the outcomes of these fractures over the last 10 years? Means publications now, are they having the same outcomes as 10 years back, or the outcomes have differed? You understood what I'm asking?
So to answer your first, yes. Second question I got it, but first question, can if you don't mind, can you repeat it?
Yeah, so basically, which particular stems are more notorious? I mean, cemented, uncemented, proximal coated, or a fully coated, or any particular pathology like rheumatoids have more incidence than osteos, or maybe angstpons and things like that. Was there any distinction in these particular fractures?
No, sir. I did not look for these parameters when I was doing the research. To find out which particular did not find out. And to answer your second question, what I have found out over the last 10 years that they are able to decrease the complications by using they are able to decrease the complications, but I have mentioned they are more using the cables and more advanced plate systems they are using. Because of that, they are able to decrease complication, but incidence of fracture have not gone down. If I got your question correct.
Yes. And what about the use of BMP? Does anyone highlight whether BMP should be used and that change the outcomes?
I did not get, sir. But I did not get the question, sir.
Okay, so bone morphogenic protein. So have they anyone
Ah.
mentioned about biologicals and that if you use that, the risk of failure is less, and if you don't use, it is more. ऐसा कुछ trial comparing
I
the
could not. नहीं sir,
modality?
ऐसा कुछ नहीं. I could not find.
Okay. That's all from me.
Arshad sir, Sachin sir, any questions?
No more question. It was a good presentation.
That is a good presentation, Avinash. No questions. Thank you.
Okay. Thank you, Avinash. And I'll invite the next contestant, Dr. Urvil, for this presentation. Please share your presentation, Dr. Urvil, and we can start.
Am I audible, sir?
Yeah,
Yes.
you're audible. Your screen is visible. Go ahead.
Good evening. My name is Dr. Urvil Shah, and today I will be discussing the posterior malleolar fractures who benefit from their fixation in 2025. Now, the posterior malleolar fractures are present in roughly 40% of the fractures around the ankle. An important structure, the posterior inferior tibiofibular ligament, is attached to it, which provides 42% stability to the syndesmosis. If poorly treated, these fractures have been associated with post-traumatic arthritis and ankle instability. Now, I would like to present two scenarios. One of that of a 45-year-old male with known case of diabetes mellitus who presented to us with a trimalleolar fracture. This patient was planned for fixation. However, he developed a poor bone complication following the surgery. On the other hand, there was an 81-year-old female who, after trimalleolar fractures, were conserved outside. She came to us with arthritis, and then we had to go ahead with the fusion. Now, we have two scenarios. One where a fixation was provided and one where it wasn't done. However, in both cases, there was a poor outcome. Therefore, to understand what was the reason and who will benefit from these posterior malleolar fixation, I did a detailed review of literature. And to discuss that, I divided them into the following categories: the studies related to the biomechanics, the studies related to the indication of fixation in the form of size of the fragment, the fracture morphology, and the articular congruity. Others related to the outcomes of fixation in the form of functional outcomes and complications. Now, I included studies from the last 10 years, which includes various meta-analysis, randomized control trials, and systemic reviews for this narrative review. Now, to understand the literature further, we need to understand the CT-based classifications. Among the various CT-based classification available, Mason and Bartoni-Sek are one of the common ones to be used. In Mason's, the type 2A, 2B, and 3 are the ones which are operated, whereas in Bartoni-Sek, it's the type 2, 3, and 4 which are operated. Now, to start off with the biomechanical studies, as the ankle goes from dorsiflexion to plantar flexion, it has been found out that the pressures increase at the level of the posterior malleolus. In this same study, Haraguchi et al. Also induced the posterior malleolar fracture ranging from the size 10% to 50%. And they found out that not only do the pressures increase from dorsiflexion to plantar flexion, but they also increase with the size of the fragment. Thereby, they concluded that more the forces, more is the chance of ankle instability and the risk of arthritis. In another biomechanical study, the cadavers were with posterior malleolar fractures. Half of them were operated with a posterior malleolar fixation, and the other half were underwent a syndesmotic fixation instead of fixation of the fragment. It was found out that the ones in which the posterior malleolus was fixated had 70% restoration of stability as compared to only 40% restoration of stability in a syndesmotic fixation. Now, moving on to an important question. Does size really matter? Well, to answer this question, we have to dive down into the past. Initially, it was said when the fragment is more than 25% of the articular surface on the lateral radiograph, or more than 1/3, it is then when you should undergo a fixation because the talus will subluxate. And for the fractures less than 25%, there is no need for fixation because the talus is not subluxated. However, this was disastrous because many of such patients developed instability, arthritis, and were not satisfied with this non-operative management. So various systemic reviews and meta-analysis were conducted right from the year 2016 to 2024. All of them tell us one thing, that what matters is the morphology of the fracture pattern, stability of the syndesmosis, presence of any chondral impaction, any articular step presence, and size should not dictate the management. Now, among this is an article by Fernandez et al., who advocate an a la carte type approach to management of ankle fractures. They have listed down the current indication for a posterolateral fixation in the form of syndesmotic instability, intra-articular step of more than equal to 2 millimeters, a tibial plafond impaction in the presence of intercalary or a loose body. Other study by Mason et al., they give the Liverpool algorithm, wherein they advocated a fixation of the posterolateral fractures in Mason type 2A, 2B, and 3, whereas in type 1 posterolateral fractures, they advocate a syndesmotic screw placement. Now, to understand the functional outcomes, we need to understand the various functional scores. OMAS stands for Olerud-Moliander Ankle Score. It's a score ranging from 0 to 100, which score higher the score, better is the result. And AOFA stands for American Orthopaedic Foot Ankle Society score. It is also a score from 0 to 100, and higher the score, better is the outcome. Mason et al. Showed that their OMAS value was almost equivalent to that of unimanual fracture fixation. In an article by Olgun et al., they found out that the AOFA score was higher for a plate fixation over a screw fixation over no fixation at all. Kalikar et al. Showed that the main AOFA score was 85, which was suggestive of a good outcome. And Lizzie White et al. Showed that their median AOFAS was almost 96, which is suggestive of an excellent outcome. And they also concluded that posterolateral fixation is associated with good mid to long-term results. Now, to understand the complications, they have been listed down by Newman et al. As follows. Among them, the delayed wound healing and infection was common with patients having comorbid status like diabetes mellitus, peripheral vascular disease, high BMI. Osteoporosis was associated with malalignment and often a revision surgery. Open fractures had a higher chance of infection. Hardware-related complications were present and they often required a second surgery. Approach-related complications were also identified. Example, the posterolateral approach often having a sural nerve injury. They also concluded that with better experience, these complications could be reduced. Now, we have understood the various everything about the posterolateral malleus fractures. It's time we should know about the various types of patients which are available. It's a spectrum, right? From the high spectrum, at the one end being the regular athletes, runners who require plantar flexion, squatting, where definitely a posterior malleus fixation will provide a very good outcome. Whereas in the other end of the spectrum, we have the life's elderly comorbid individuals, where there is a higher chance of complications. In these cases, we should assess the risk-benefit ratio. Patients, and we should tailor our approach in the form of modifying the implant choice or the approach. I would like to summarize by saying that management is morphology driven, not size dependent. Pre-op CT is essential. Fixation improves the syndesmotic stability, and our approach should be to fix the patient, not just the fracture. We have to go from a more surgeon-centric approach to a patient-centric approach. We also can learn from the three wise monkeys that to ensure maximum output, don't forget to see the fracture morphology, don't forget to hear the patient demands and comorbidities, and don't forget to speak regarding the complications and the rehabilitation. These are my references. Thank you for your time.
Thank you very much. I'll invite the judges for questions. Go ahead, Satish.
Yeah. Urvil, that was really concise and very well presented, I must say.
Thank you, sir.
So I have a couple of questions. One is you mentioned 4 patient scenarios from sedentary to super active, and you said your choice of implant and fixation method would depend on that. So how would it change if you have a posterior malleus in a sedentary person or a high demand athlete?
So I have reviewed multiple literature studies, and it has been shown that a plate construct is far more superior than a screw construct. So for a high demand athlete, definitely a plate construct should be advocated, unless the fragment is very small that it is not amenable to a plate fixation. Whereas in case of a sedentary lifestyle, if we can, a screw fixation could provide a better outcome because of lesser tissue dissection, lesser handling of the tissues, and better skin condition, and to avoid any skin complications.
So does the screw insertion require lesser soft tissue dissection?
No, sir. In the form of percutaneous approaches have also been advocated for these patients, sir. Though they provide a lesser, the fixation is not that sturdy as a plate, but a percutaneous construct is an option.
And you said that the posterior malleolar fixation provides 72% syndesmotic stability compared to 40% of a syndesmotic screw.
Yes, sir.
So if you have 70% syndesmotic stability with the plate, what do you do for the remaining 30%? I mean, 30% of these patients will still have instability after fixing the posterior malleus.
So that was a cadaveric study, and what the authors have advocated is that after we should always keep everything handy, and after we fix the posterior malleolus and we fix the fibula and we fixed all the fractures, we should go ahead with the hook test or external stress view. In which condition, if there is an opening, we should go ahead with the syndesmotic screw. However, in most of the articles which I have went through, they have said that in very few cases they have required an additional syndesmotic screw.
Okay, so a posterior plate plus a syndesmotic screw.
In case if it is yet unstable on intra-op assessment.
Thanks.
Urvil, what have they mentioned in all these articles about the approach for the posterior malleolus? Whether a posteromedial approach would be an ideal approach if there's a big posteromedial fragment, or whether a posterolateral approach would give us exposure better than the posteromedial approach.
So for a big, large triangular fragment, which is the type 3 Masons, they have advocated, the Liverpool algorithm says to go for a posteromedial approach. But whereas in case if there is a smaller fragment, which is just predominantly a posterolateral, which is basically a type 2A fracture, they advocate a posterolateral approach, especially if there's an additional fibular fracture. In cases where there is a posterolateral and a posteromedial fracture, if they say that you should take both the approaches, ideally, but there should be a 6 centimeter skin bridge between your two incisions.
All right.
Urvil, okay, Ashish, you go ahead.
You mentioned about hardware failures and the chance that it gets better. So, are there any differences in usage of plates versus screws?
Yes, so the chance of a hardware prominence was definitely more and complications were higher with plates in comparison to screws. That was what I found out.
Right. And the other thing is the title of the talk was Who Requires Fixation, right?
Who benefits from fixation? Yes, sir.
Who benefits from fixation? Yeah. So, I mean, an extension to Dr. Satish Muta's case was you have two different sets of patients. One is an elderly patient and one is an athlete. So, I think an elderly patient would also require to fully weight bear. In fact, the athlete will listen to you and not comply with your instruction. But an elderly patient is less likely to.
Yes, sir, absolutely. It is essential. I'm not saying that we don't have to fix the fragment, but we have to keep in mind that the other things also, we should see the patient as a whole. And in case of that, instead of a plate, if the fracture is amenable to screws or percutaneous screws, that would probably provide a better outcome in terms of lesser chance of complications, sir.
Did any of the studies talk about percutaneous screws nowadays? I mean, are people using percutaneous screws now?
No, sir. They advocated more of open reduction only, not percutaneous screws.
Okay.
But yeah.
Urvil, good presentation. Little bit an algorithm of fixation, like when you put a screw, when you put a plate, one. And second question, whether your fixation method will change if there is a trimallear fracture or ankle dislocation.
Sir, with respect to algorithm, as I said, it is very much dependent on this axial CT scan. We take an axial CT cut. In that, we have to assess the type and you have to classify. So if it's a large if it's a large triangular fragment, a plate fixation is a very good option. Whereas in case of if it is two small fragments, like if it is just a small posterolateral fragment, and intraoply, if we find that the fragment is small, a screw fixation would be better. But in case of when there's a posterolateral and a posteromedial fracture, in those conditions also they advocate a plate. Secondly, sir, if the patient has a trimallear fracture, in that case, the kind of the order of fixation which I have read and through the various articles I've read, they've said is we should first fix the posterior malleolus fracture, followed by that the lateral malleolus, and then the medial malleolus. The reason for that, they say, is once we fix the posterior malleolus, the PITFL with its ligamentotaxis assists in the fibula reduction and achieving its length.
Maybe you have to be flexible, like you can fix posterior malleolus first or lateral pelvis, depending upon the
Yes, sir,
you know,
there
the
are
injury.
two
But
things.
I don't, yeah, go ahead, go ahead.
Yes, sir, in few articles they advocate, like Mason et al. Have really advocated to go ahead with the posterior malleolar fixation first. But however, various other studies, especially the ones of Fernandez and Haraguchi, they say that we should fix the lateral malleolus temporarily, then go ahead with the posterior malleolar fixation, and then do the definitive fixation of the lateral malleolus. This would assist in the lateral malleolar reduction and posterior malleolar reduction and will not interfere with the fluoroscopy intraoperatively.
Okay, thank you.
Thank you, sir.
Thank you.
Thank you very much. I think there are only two contestants today.
Who's this,
Okay.
Dr. Akhil? He is not a contestant today, is he?
Chauhan and Athawale have not come.
So today only two contestants. Only two,
Yeah,
Ashok?
only two contestants. So Chavan and Athale are not here.
ठीक है.
So we have Avinash and
Okay.
Urvil today. That's all.
Okay, thank you,
Okay.
Avinash, and thank you,
Thank you, sir.
Urvil. Yeah,
Thank you, guys.
both of
Thank
you.
you.
Thank you, sir.
Thank you, sir.
Thank you.
Okay, bye.
Bye, Ashok.
Bye.
Bye,
Good
Gautam.
night.
Thanks, Ashok.
Bye-bye. Good night.
Good night.
Yes, Mershi, you end the session. Stop the recording.